Hello, my name is Tom Buchholz, and I have the pleasure today to moderate today's tumor board discussion. And first off, I'd like to introduce a truly outstanding multidisciplinary panel who's going to be talking over our cases today. First, I'd like to introduce Dr. Frank Vicini. Frank's representing radiation oncology. Dr. Vicini, can you tell us a little bit about yourself?
Sure. I'm based in Michigan. I'm fellowship trained in breast cancer radiation therapy, been involved in clinical trials through the National Cancer Institute and even internationally. So my focus is on early stage breast cancer and reducing long-term morbidities.
Thank you, Dr. Vicini. For our surgeon today, we have another national thought leader in breast cancer, Dr. Terry Mamounis. Dr. Mamounis, would you care to introduce yourself, please?
Yes, thanks, Tom. Terry Mamounis, I'm a breast surgical oncologist based in Orlando, Florida. Direct the comprehensive breast program at the Orlando Health UF Health Cancer Center. I also work with the NSABP and now NRG Oncology as the chair of the breast cancer committee, and have been in the business of designing and conducting clinical trials for almost 30 years.
Thank you very much, Terry. And representing medical oncology, we have Dr. Ruth O'Regan. Ruth, would you mind introducing yourself, please?
Yeah, hi, I'm Ruth O'Regan. I'm a breast medical oncologist from the University of Wisconsin, also Deputy Cancer Center Director of the Carcinoma Cancer Center. And my area of interest really is in clinical trials in resistant breast cancers, including triple negative breast cancer. So I'm very happy to be here and look forward to discussing these cases.
Thank you, Ruth. And finally, the fourth panel member representing diagnostic imaging and radiology is Rennie Butler. Dr. Butler, would you introduce yourself, please?
Hi, and thank you. I'm delighted to be here as well. I am a diagnostic radiologist with a specialty in breast imaging at the Yale New Haven Hospital and on the medical faculty of Yale School of Medicine. I'm also participating in clinical trials. My main area of interest is digital breast tomosynthesis, which is a relatively new technology that has made mammography a better test, as well as breast MRI. And I look forward to discussing these cases with the panelists and learning from each other.
Thank you, Dr. Butler. Dr. Mamounis will be presenting our fifth case. It's a lady with ductal carcinoma in situ, or non-invasive breast cancer. Dr. Mamounis, would you tell us a little bit about her history?
Yeah, so this is a 46-year-old female who presented with a right palpable mass, which is essentially in the upper part of the breast, but at the edge of the nipple area. She has family history of breast cancer, mother at 64 and maternal aunt at 38. She had genetic testing that was negative. And we can look at the images in a minute, if you like first, or we can look at the pathology.
Dr.
This is an interesting case of DCIS from an imaging perspective because, of course, it's the minority of cases of DCIS that present with a mass, only about 10% that present with non-calcification findings. And it appears to be the case here, where in the right breast at approximately the 12 o'clock position, we see an irregular mass that we also see here and in the right breast on the ultrasound. The MRI, the role of MRI in DCIS is an interesting question. It's one that is debated. In the early days of MRI, it was believed that MRI was not very sensitive for DCIS. And it's true that it's not as sensitive for DCIS as it is for invasive carcinoma, but it is still the most sensitive modality we have, even for DCIS. So to give some perspective on that, mammography detects approximately 70 to 80% of DCIS cases, while MRI has been reported in different studies to detect DCIS in the range of 77% all the way up to 96%. And what's also interesting about DCIS and MRI is that the types of DCIS detected by mammography and MRI are slightly different. MRI, of course, relies on the presence of vascular enhancement due to metabolic activity, and therefore it tends to preferentially detect high-grade DCIS. The DCIS cases missed on MRI tend to be low-grade DCIS. And so you may argue even that those are potentially the cases that would not ever become clinical, and that perhaps that's not even a limitation of MRI to miss the lowest grade DCIS cancers as long as it detects the higher grade ones.
Thank you. Dr. Mamuna, so do you often see palpable disease with ductal carcinoma in situ? And if you get a biopsy that shows DCIS and palpable disease, do you worry about a sampling error?
Yeah, it's not a situation that we encounter very often, although it's not rare. I've seen several cases of palpable DCIS and sometimes sizable DCIS, 4 or 5 centimeter masses that despite sort of multiple core biopsies and eventual surgery, had only non-invasive disease. Now, you always, of course, worry about areas of microinvasion when there's a large palpable DCIS. And of course, we discussed that with the patient that when we take this out, there could be microinvasion or frank invasion identified. And of course, there's always the concern when you have a large area of DCIS that even the pathologist potentially can miss an area of microinvasion. And on occasion, very unfortunately, we can see patients who had DCIS, treated for it with mastectomies, let's say, and then a few years later, there's a distant recurrence. We kind of scratch our heads as to how this happened. And the underlying theme is maybe that there was some area of microinvasion that even the pathologist did not tend to cut and test at that point. So yeah, it's not a common situation. It's pretty uncommon, but it can happen. And so in this case, as we discussed, it was DCIS grade 2 to 3 with necrosis, both ER and PR positive.
So it sounds like you must encounter a lot of breast cancer patients who right away the first concern that they have is, I want to have the most aggressive treatment. Please remove my breast, and it might spread to my other breast. Please remove my other breast. This case is a little different because of her family history, particularly. But how do you approach conversations concerning contralateral mastectomy? I'm sure you encounter this quite frequently.
Yes, pretty much. I think we encounter this almost with every patient that we see. We have to go through all the discussions. And so we talk about, first of all, are they candidates for breast conservation or mastectomy? If they are breast conservation candidates, obviously we steer the discussion more and towards that because that alleviates a lot of issues. However, there are situations where you have to pay attention to the contralateral breast as well. So if the patient is a candidate for mastectomy, then obviously sometimes it makes it an easier discussion to some extent what you do with the other side or not. And as I mentioned earlier, there are also issues of symmetry and reconstruction and so on and so forth that may help that decision. But some of the factors that we take into account when we discuss unilateral or bilateral mastectomy is the age of the patient, because that gives us an idea of the potential time interval that the patient is exposed to a contralateral breast cancer. And this 46-year-old here has at least 40 years life expectancy, even 45 years life expectancy by the time she reaches 85 or 90. So there's quite some time to develop an additional breast cancer. I typically tell patients that the rate of subsequent breast cancer, either in the contralateral breast or in the ipsilateral breast, if they have breast conservation, is about 0.5% per year. So when you add both breasts, it's about 1% per year. That's with no additional hormonal therapy. So for example, that would be applicable for a patient with triple negative breast cancer that would not get hormonal therapy. So, but with hormonal therapy, we reduce that risk almost by 60%. So if we sort of do the math, in a 46-year-old has another 40-year life expectancy, we typically would expect about it's not quite 40%, maybe a little less, 30 to 40% risk of developing a cancer in either breast, right? And half of that for the contralateral breast. But that 40% can become almost 15% by using hormonal therapy. So that is an important part of the discussion, because in a 46-year-old who has about a 15% risk of another breast cancer in either breast, that's not that dissimilar for any average woman that has about a 12% risk of developing breast cancer in their lifetime. So we put that discussion and frame the discussion in the background of what happens to normal women. But sometimes it's also a decision that the patient wants. And in this particular case, with bilateral mastectomy, her age at 46, although she was technically a breast conservation candidate, although the mass was sizable, she opted for bilateral mastectomy. So that's essentially what we did. Now, of course, as I mentioned before, we discussed skin sparing versus nipple sparing mastectomy. There's two reasons why somebody may not be a candidate for nipple sparing mastectomy. One is the proximity of the tumor to the nipple, and it was somewhat close, but not involved in the nipple. But the second is the breast habitus, so to speak. If there's a lot of ptosis in the breast, then nipple sparing mastectomy is not a very good option. So for those reasons, one or both, this patient actually ended up having a skin sparing mastectomy on both sides and right sentinel lymph node biopsy with an immediate expander placement.
So we see the pathology there. Indeed, she was confirmed to have ductal carcinoma in situ without invasion. Why, when there's no invasive breast cancer, would you do a sentinel lymph node procedure? Because the sentinel lymph node procedure implies to get to the sentinel lymph node, you have to invade into the lymphatics.
Yeah, good question. And obviously, there are two reasons for this in this particular case. Palpable DCIS, you can't rule out microinvasion. So essentially, this is the main reason why you do a preemptive sentinel lymph node biopsy in case the patient has microinvasion. Now, you can say, if a patient that has a lumpectomy, I wouldn't have done a sentinel lymph node biopsy. I would have done the lumpectomy, find out if there is microinvasion or invasion, and then return to the OR and do a sentinel biopsy if there was microinvasion or invasion. But for mastectomy patients, you don't have that option. If you perform the mastectomy and then invasion is found in the final pathology report, then it's very difficult to map the skin of the flap and get an adequate sentinel lymph node biopsy. It can be done, and I've done it occasionally. If somebody that comes from the outside and had already a mastectomy unexpectedly was found to have an invasion, and sometimes it works, but it's not necessarily an ideal situation. So for patients that have mastectomy, we typically would do a sentinel lymph node biopsy at the time to make sure that if there was microinvasive or invasive cancer, we cover all bases.
And then the margin issue on this case, it looked like it was coming close to a particular margin. How did you know where to go back and remove additional tissue?
A good point. So it depends on how you did the mastectomy, right? If usually we do sometimes a periareolar incision with vertical extension, which happened in this case. And so knowing the location of the tumor in the breast, when we get a margin very close, and they mentioned that it was the anterior inferior margin, so I know it's on the lateral part of the inferior flap. So once he goes back for the expander to implant exchange, we can open that skin and remove additional skin and put it back. So we have done this a few times when we know approximately where the positive margin or the closed margin was located. And essentially, it doesn't make a big difference for the patient because he's already in surgery for having the expander to implant exchange. So we remove some additional skin, which doesn't change her cosmetic result at all.
When you do a mastectomy, Dr. Mamunis, when you go down to the deep margin, on top of the pectoralis muscle, there's this layer of fascia. Do you tend to remove the fascia? Because oftentimes with DCIS, Dr. Vicini will get a report and it will say, DCIS comes up to the deep surgical margin.
Yeah, we typically remove the fascia just to make sure that we at least, have a good posterior margin. But that situation is not that uncommon either. Sometimes the tumor may come back to the posterior margin. And usually for that, we allow radiation. We usually don't go back. But again, if radiation is not to be given, then sometimes you can consider that. The problem a lot of times nowadays is that we put the expanders now in our place, and I think in most of the country, prepectorally. So in the past, we used to do them retropectoral, so then you could have opened the skin up and remove a little bit more muscle or fascia. But now that you have the expander sitting on top of that, you really don't have that option. I say you really don't have that option. We have been in that situation sometimes where we ended up going back and removing, essentially lifting the expander from the chest wall, removing tissue behind it and put it back. So you can do it, but it's not, again, another ideal situation, particularly when you do a prepectoral reconstruction.
Dr. Ficini, any role of radiation after mastectomy for DCIS?
If at all possible, we prefer not to use radiation after mastectomy for DCIS. The only indications really are what Terry has talked about. It's the margin issue, right? And certainly if he can give us a better negative margin with a small surgical procedure, that's the route we want to go. In this particular patient, it sounds like she has no indications for radiation, which will give her obviously a better cosmetic result in the long run.
And Dr. O'Regan, any role for hormonal therapy for ductal carcinoma in situ?
Well, I think not in this case, because obviously we give the endocrine therapy to prevent further breast cancer events, and we know it's effective in doing that. But since she's had bilateral mastectomies, I don't think there's any indication to give her endocrine therapy. And of course, there are quality of life and toxicity issues with those agents, so I would not recommend it.
How about if she had just a unilateral mastectomy and still had her contralateral breast intact?
Yeah, that's a good question. I mean, I do talk about endocrine therapy in those patients because, the randomized studies that were done did show a benefit of the contralateral breast. So I guess it's a risk-benefit type discussion. I don't generally push very hard, but certainly if there's somebody who wants to do everything, I certainly would consider it.